Hello, my name is Nick, and I would like to welcome you to my series on my BPT journey. This presentation is my own opinion and is not endorsed by any other group. I sat both exams multiple times, and it took me 7 years to complete the process, which may sound like the opposite of an endorsement, but through this rocky journey, I had to keep reflecting on and reapproaching this process from numerous angles, which has provided me with what I consider a number of useful insights which I intend to share so that you may have a smoother journey. This, however, is not a rule book, and you should simply incorporate the points which help you. This presentation is the 5th in my 10-part series and focuses on the long case of the clinical exam. I truly believe that perfecting the long case is the process which helps you become a better doctor by developing an in-depth, holistic approach that not only focuses on the patient but also their social constructs. So though at points you may dislike practicing it, I encourage in committing to this part of the process. Now, before I move on, I want to draw your attention to this picture. I have put the marking schema here as not only a pretty piece of symbolism for the slide, but because it is important to understand it intimately, as doing so will allow you to understand the expectations and partially gamify the exam process. But more on that later. I would recommend when first attempting history taking for a long case, start with a generic structure and aim to gather all the required information in the set time. Possibly consider pre-blocking out sections of your manila folder as a template. Then, once you have mastered this process and don't require the pre-labeling, adjust your approach based on your personal style and the feedback you've received. You can also consider making a similar transition from a generic style to a more personalized style with regards to the presentation of your long case. On this slide, I have blocked out a very simple diagram of how you can approach dividing up your manila folder. On the front, having your first 5 minutes on the left, and then your medications listed on the right. However, in the actual exam and many of your mocks, you'll be given a list of medications and therefore do not need to replicate this here. On the inside, using the first 2 columns to discuss your issues, the third column to expand on all other parts of the past medical and general medical history, and then the last column to conduct your social history and examination findings. And then on the back, mapping out your introduction, conclusion, problem list, and plans for your problem lists. This is again something that is personal and something that you can adapt. It's also not necessary to use a manila folder. Many people use palm cards or entire sheets of A4 paper. So it's best to just keep practicing and find out what works well for you. Going forward, I will now give a general approach to the different stages of the long case process. There are many steps to cover, so this presentation will be a little bit longer than my others, but I hope it provides a very thorough overview for you. Again, I just want to stress that this is a personal approach, and this is merely something that I want you to build upon. So the first 5 minutes, or for some people 10, depends again on your style, are very crucial. Your aim here is to set the tone and to avoid any surprises in the future. With regards to tone setting, it's good to apologize for the need to cut the patient off and for talking quickly. You should emphasize that this isn't how you usually conduct consultations, but that the patient has a lot of history to cover and you have limited time to gather it. So therefore, in this circumstance, this is necessary. This approach of apologizing won't be foolproof, and often you will need to remind the patient about the time constraints and to cut them off. Many struggle with cutting patients off, but it is a very necessary part of the examination process. A tactic which seems to work is to say to them, that sounds interesting, and I will ask you about that later. But first, can we discuss and then proceed into your question? Whether you come back to it is often based on time remaining and relevance. But in these circumstances, the patient feels heard and often doesn't mind either way. Obviously, for many of the patients, they're giving up their time to help you. So please remember to be polite as possible during these history taking. It is not uncommon to hear of a patient mentioning their recent heart attack when you are discussing their past medical history, which is usually well into your history taking time. These instances not only affect the flow of your history taking and presentation, but can also mentally jar you. So it is important to get the full lay of the land at the start. So to avoid any surprises, I would usually try and tackle all of this within the first 5 to 10 minutes. I would start by first requesting a shopping list of medical conditions, outlining to the patient that it is simply a list and that I don't want any details. Then I would do a quick systems inquiry, trying to identify anything missed, again, preventing any details. I then would go to reviewing the medications, and which I would do silently. And as I reviewed them, I would compare them to the list of the conditions. If I found any medications that I could not account the condition for, I would therefore make the effort to ask the patient specifically about them. Next would be to clarify the patient's allergies. This is particularly important when it comes to your discussion of management, as it can be very detrimental for you to recommend any management that does not consider a patient's allergies. I would then clarify recent admissions and the number of admissions in the last 12 months. Smoking, alcohol, illicit drug use. Family history, usually this is brief, but it could be useful for risk stratification. Falls in the last 6 months and use of mobility aids. The presence of falls is usually very important to find and is often gold in discussions. Accommodation, knowing who they live with and how much support they provide, and where they live, whether it's rural, and whether they have any difficulty with transport getting to appointments. Again, very crucial for management discussions. Next, we'll move on to occupation or pension to assess their financial needs. Then driving, whether they are independent. And then also, if I have any concerns around cognition, sight, or sensory issues, again, making sure to ask about driving, as again, this is an important discussion point. You must always ask about the patient's biggest concern. It cannot be understated that this is crucial to passing the exam. And then insight. Doesn't necessarily need to be asked now, but it's something that you should be considering of whether there is any discordances that you've picked up through your discussion, and whether a questioning of insight is important for future planning or management issues later. In the actual exam, make sure to ask again if there's anything that the examiners asked which you didn't. What their focus was when they were taking the history and what their focus was when they were doing the examinations. These can be gold questions, so please make sure not to forget them, particularly as it's not part of your usual process when preparing. After I have gathered all this information, I then take a minute or two just to process it, and I want to decide what the biggest issue is. It's either the patient's biggest concern or an issue which threatens their life. And if they're not recognizing this high mortality risk, this is when you have those insight considerations. You also want to identify what other two issues you will address. You'll be particularly focusing on issues that impair patients' quality of life or have a high mortality risk. So really, you want to know what are the keystones of the body of your presentation at this point in time before going any further. With regards to history taking, you should set yourself 30 to 35 minutes to collect all the following history. At the start, you won't be able to do this. It will take a lot longer, but this is something that you should work on and aim for, because the more strictly you're able to stick to your time limitations, the more thinking time that you'll have towards the end, which usually ends up being more crucial. Other important things to remember to achieve these tight time constricts is to collect the history in the order that you want to present it. Now, this is something I want to stress in particular, as collecting the history in the order that you want significantly helps with your presentation and your synthesis of the case. So this is why you must cut off the patient politely and take control of the order of the history taking. You should also watch the clock while you take the history, as you may need to adjust the depth of information you're collecting or potentially the number of key issues you address. Once you've identified the issues you want to cover, it is time to gather the information about them. The order that I like to use would be firstly discussing the presentation. Usually this is a brief if the diagnosis is known, simply knowing at when, at what age, what symptoms, if there was delay in diagnosis. If it is more of a symptom rather than a diagnosis, then more detail is usually required in the presentation section. Next, you address the risk factors. You just want to list the risk factors and have the patient respond yes or no. Investigations. How was the diagnosis confirmed? Be suspicious if not conventional. This may mean that they have a poor recollection of their diagnosis, and it's something that you can dive into more either in your history taking or in your discussion. Or if it's a diagnostic dilemma, then clarify what has been done so far and what are the associated results. Then I tackle issues since diagnosis up until recently. I want to know number of hospitalizations, lines of medical management, and why they moved to a next line of management due to either reactions or lack of response, whether there's been an impairment of function or mood secondary to the diagnosis. Again, though, you want to keep this section brief because if it is current or still relevant, you're going to elaborate on this soon. And then management, particularly focusing on current management. You want to know about how they manage their condition themselves, how they monitor it, what are the pharmacological and non-pharmacological management, if they require assistance or overseeing from the health system, be that specialists, GPs, allied health, and how frequently they see them, where they see them, what investigations were used. Then I move on to current status. I want to know the symptom burden from the disease and the treatment and the level of impact, basically the biopsychosocial approach to know the limit of their function. Compare the recent investigation results against the targets. Question about adherence, not only to medications, but also appointments and screening. For example, skin checks on immunosuppressants. Knowing the information about the current status and how it impacts their quality of life is extremely crucial. This shows that you are thinking about the patient in front of you and that you are looking to make management plans that will work for them, not just a simple regurgitation of textbook knowledge, and thus this will lead to higher scores. Last, progress and prognosis. If poor, then discuss if changes to management have been discussed, such as appropriateness for surgery, dialysis, change of chemotherapy, and also if future planning discussions have taken place. And again, you can consider level of insight at this time. This is my structure. There are, however, numerous ways to approach this. I adapted this from the more famous PRIC MCP method, where I changed complications to issues since diagnosis. I did this because mentally it helped me from doubling up on information, as it prompted me to split the presentation of complications by recency between the issues and the current status sections. This allowed me a better flow of my presentation and saved me time. However, I stress this was a personal decision after trial and error, so please remember I encourage you to adjust my guide to suit your style. For past medical history, you're just briefly checking the status of other current medical conditions and their management. You should already know they're not as important from your initial screen in saying that they're not one of your top big items of discussion. And if you are questioning why you didn't elaborate on this later, you can explain your thought process. You should also double check unaccounted for medications if not already raised, and then also the level of compliance and level of independence to self-administer. Again, this may have been already covered, so don't double up. Check if they are up to date with all age-relative preventative health screening and vaccinations. If not already discussed, about relationship with GP and how frequently they see them. Again, discuss, if not already, their diet and exercise, and if relevant, their sexual health. Note, I have not relisted their allergies, alcohol, smoking, illicit drug use, family history here, because you should have gathered most of that information in the first 5 to 10 minutes. Then move on to social history. Again, some of this has come up already in the initial screening or discussion of issues, so don't repeat yourself. If you've covered it, just jump to the next one. You'll start with accommodation. Who do they live with? The health status of their family members, other social supports, location of residence, layout of house. Here you're usually asking, has an OTC in the house, and the location and number of steps. Behavior, their ability to complete the ADLs, be that complex ones of shopping and finances or the more basic ones of personal hygiene. Whether there's in place any formal assistance or an ACAT. Then assess their mood, which can be done with a simple 2-question questionnaire like the PHQ-2. Driving, assess their safety, if they consider them safe driving, and if they don't drive, what transport do they use? Employment, are they still working and what their role is? Finances, the sources of their income, if they're on a pension or using their own savings, but you particularly want to know if they believe their finances to be adequate to pay for their medical expenses and transport. You can also ask about home ownership, if it's rented or if they have a mortgage. You want to know if they have a will, an EPA, EPG, or an advanced health directive. Ask about hobbies. And particularly, you want to know if they have had any impairment with conducting their hobbies due to their conditions. This is, again, discussion gold. And then last, a quick question on insight. I like to ask, where do they see themselves in 5 years? This is particularly important if you think there's a high mortality risk ahead of them and whether you question they recognize it. For those who like mnemonics, the approach I've shown here is known as the A to I method. And I would recommend starting with this, but again, adapt it to your own style. Again, just going to stress this. Ask if there's anything the examiners asked which you didn't, and then ask what their focus was when they did their examination. Again, this is not part of your usual preparation process and why it is important to drill it in. When you're doing your examination, it is a target examination. You want to assess the current status, functional impairment secondary to, possible side effects for management of, and possibly the relevant negatives if there's a diagnostic dilemma for each of your 3 or 4 big issues. You also want to do a general overview of the patient. It is also very appropriate to ask further history-taking questions during this time and to further clarify. That is very commonly done. So after you've collected your history, the next step is consolidation of the information gathered into your presentation. The amount of time you'll have to do this is whatever's left of the hour plus another 10 minutes. These extra 10 minutes are usually taken outside the room, away from the patient. So having some time left within the hour to actually clarify further things is usually quite important. Within this time, you want to write out an introduction and conclusion. You want to write an issues list and then dot point key points underneath each with respect to your management plan. If it is a management issue, you want to first confirm information gathered either through repeat tests or collecting from other sources. And then you want to develop a biopsychosocial approach with consideration of both pharmacological and non-pharmacological measures, followed by safety netting and supervision. If your issue is diagnostic, you want to start with first confirming the information gathered, and then next the investigations in the order that you would conduct them, as well as what findings you would expect. This is then followed by safety netting, supervision, additional support that the patient may require while you are getting to your diagnosis. So usually this is either social or symptom management considerations. Now, before I read these slides on a structure of presentation, I want you to remember this is a rough guide. It is just some scaffolding for you to build off. So the introduction, rough guide is Mr. X is an ex-old X who works as X and particularly enjoys X. He has an X history of X, or alternatively, this is more appropriate, or is currently an inpatient for treatment of X. On a background of active problems of X, includes social problems, not just medical issues here, and has inactive problems of X. So here you're listing any big ticket issues in the past medical history, though these ones aren't as relevant and won't be elaborated on. But you want to note that you've noted them, though you might not discuss them as in length. Then moving on, his main concern is X. I will begin by discussing his X, which is usually the number one issue, as this is essential for framing X, which is usually his current quality of life, his functional status, his mortality, morbidity risk. You'll get more of a flow of this as you do your own. With regards to presenting your issues, start with the same similar flow as how you took the history. So presentation, the X was diagnosed in X at the age of X when he presented to his GP with an X months history of X. Risk factors, the presentation occurred in the context of X. Investigations, his X was confirmed with an X, which results consistent with diagnosis of X. Issue since diagnosis, since this presentation, the disease course has been X, which is usually either tumultuous, increasing, decreasing, with most recent flare being X. Also has had X number of hospitalizations and X lines of therapy. Management, Mr. X monitors his X via X. His management of X involves the non-pharmacological measures of X. And if it's not matching with guidelines, you need to explain why here. His pharmacological management of X is currently X. So this is make a reference back to previous issues with other lines of management if appropriate. And he reports adherence issues with regards to X. His care and management is overseen by X, who sees, and then it's a question of how frequently they see him. Then going on to the next section of presenting your issue. Now this is particularly important because, as I said, it's the current symptoms and the current status which allows you to personalize everything and will score you those higher marks. And then the progress, current function, prognosis is also extremely important for that management discussion later on. So with regards to current symptoms, with this current regime, his X is managed suboptimally or well, with scores of, and then you can use actual severity scores if you have them appropriate to have them available to give. Specific complications for Mr. X associated with this poor control are, and then you really want to go into how it impacts his life. So issues are the number of presentations, management issues, current status or response to management, impingement on his life and function, relevant negatives. You can also tie in exam findings here, such as demonstrated dyspnea at rest. However, if you do tie in the things here, which you should if you can, make sure not to double up when you present your examination findings later, just as this saves you time. Then moving on, progress, current function, and prognosis. So despite or due to these complications, Mr. X is able to live X. So it's either going to be live independently or conduct his hobbies. However, this may change with X. Now this is based on his previous trajectory, likely to increase in severity. So you're likely going to say that he is currently able to do drive independently, but this may change with his further impairment of eyesight, secondary to his worsening diabetes. As well as the clear associated mortality or morbidity concerns, Mr. X is particularly concerned that X. And this is sort of a insight demonstration of whether he has the same sort of mortality morbidity concerns as you, or if there's a difference. Then back to the body of your presentation, moving away from your issues onto the rest. You would then go on to discuss other past medical history. Now, the level of depth is really dependent on the amount of time remaining and can be as brief as the condition is stable and they take these medications, and then moving on to the next. Then you'll discuss any medications you haven't already discussed in your issues, mainly just listing them. Then compliance and any barriers to compliance, including logistics of administration, if further information is required or not touched on previously, allergies, vaccinations and preventative health, and their relationship with their GP. Next, you'll discuss family history, though this is usually very brief. Following this, alcohol, smoking, and illicit drug use. This is very important. The presence or concerns with any of these is discussion goldmine. Then diet and exercise. Important to touch on, particularly if you have any concerns with the patient being overweight. And then lastly, sexual history, which can be very important for some conditions, but for most, it's usually just a quick question if they have any concerns or issues. Lastly, we'll move back to the A to I method of the social history, remembering not to double up. Again, this is just a repeat of what I discussed. So you just basically move from A to I, skipping anything that you've already touched on for time constraint purposes. Next is presenting your examinations. So start with a present overview. So on general inspection, Mr. X appeared as X, which is usually appeared well with no signs of distress, something very, very brief, or possibly appeared overweight with mild signs of dyspnea. It's just to give an overview before you jump into the targeted examinations for each of your issues. Again, the level of depth is dependent on the time remaining, so make sure to only give the pertinent findings, but that doesn't mean to not look for the relevant negatives, and as there's highly likely that you will need to elaborate on these extra findings in the discussion. However, I want to just sort of push back on that a little bit to make sure you understand that you don't want to skip your examination findings or to not state anything that is pertinent or important. You mustn't do that. It is actually very common when time is running out during the presentation for candidates to sacrifice the depth of this section too much to actually leave out important information. But this is actually a huge mistake. When you look at the marking schema on that earlier slide, one of the 5 columns is actually dedicated to examination findings, which means you are actually jeopardizing 20% of your marks. You are much better to actually slim down your past medical history, preventative health, and social history to just key points rather than to try and over-reduce or oversimplify your examination findings. Then moving on to the summary. So you'd say in summary, X is currently either recovering from X, stable, mild, severe, active, in remission. This patient's main problem is X. In addition, he faces the future ongoing diagnostic or ongoing management problems of X. Today, the issues I would like to discuss are: now, the quality of your conclusion is not really marked at all, so it's best to just keep it short and get to your issues quicker because they are way more important. Now, I want to touch on the importance of synthesis. An important thing to note with the language you use is that the language is medicalized. It is not just a regurgitation of the patient's account. The patient may say, I stayed in hospital for 3 days when I had a chest infection. I have had this happen a couple of times. I think it is due to the treatment of my rheumatoid arthritis. Through your training, you instead, when presenting, would say, Mr. X was admitted with community-acquired pneumonia, a recurrent issue in the context of known immunosuppression for his rheumatoid arthritis. Basically, you need to start by making sure you're talking in the third person and not the first. And then once you've done this, you incorporate medical jargon instead of lay terms. These 2 changes will automatically make you sound more professional and will put the markers in the mindset to give you a higher score. Then you're moving on to your issues list. Now, issues are not a problem list, and that is because they require a context around the problem that shows that you understand the importance of that particular issue for that patient at that point in time. I want to particularly point out that if you find an issue where there is a balance between 2 factors, be that immunosuppression for transplant versus active cancer, then you should highlight this and prioritize it further in your issues, further up in your issues list, because though there is rarely a black and white response to these sort of questions, and your ability to therefore talk through the competing interests confidently and safely is always or mostly going to score you very high marks. Additionally, with prioritizing issues, the patient's main concern should always be in the top 2 issues. Usually only an issue with a high mortality risk will be considered a higher priority. Sometimes the patient's major concern can seem like a very insignificant issue compared to the numerous life-threatening issues, but in these cases, make sure to be clear with the context, outlining the distress it is causing the patient, or possibly indicating the need for education so that the patient can have a better understanding to evaluate their issue. So a structure for presenting your issues will show the necessary context for that patient. So you want to have an issue with the issue. You want to show relevant risk factors and trajectory and how the context of it affects the well-being or function of your specific patient. An example would be, my first issue is the management of Mr. X type 2 diabetes, which due to his multifactorial poor control has already caused a number of complications. I'm particularly concerned about his impaired insight and peripheral sensory neuropathy, as Mr. X is a commercial driver. And from there, you've set yourself up well for knowing the issue, knowing where it is and where it's going, and how it can really impact the patient's quality of life. And that will usually be very well received. So then after you've presented your issues, you progress to discussion. Now, you may be interrupted before discussing your issues for clarifications on some details. This is completely normal, happens more often than not, and is not a bad sign. However, I want to state that you may not be interrupted, in which case, don't pause and wait. You should just start to begin your issue. If they want to ask you questions, they will stop you. With discussing your management plans, there is a structure to the discussion. Start with your large concepts and then flag the smaller steps within them. Then, if prompted to do so, take the first smaller step and outline the smaller steps and components within. Using these structures of stating the bigger picture and just highlighting the smaller intricacies but not expanding on them is very useful, as it allows you to demonstrate a lot of information quickly without showing too much depth. It is also important to signpost during this elaboration, because these signposting structures, such as saying in a bio, then psycho, then social approach, or I would manage this in both pharmacological and non-pharmacological management, twigs to the examiners that you have a structure and puts them in a mindset to give you higher scores. So, for example, for Mr. X, with regards to the management of Mr. X's type 2 diabetes, particularly with a focus on optimizing his control and reducing the progression of his associated comorbidities and their implications. I would firstly corroborate the information provided, then address the limited understanding underpinning his poor adherence and monitoring, before adjusting his management through non-pharmacological means, namely diet adjustment with the use of a dietitian, before considering adjusting his anti-hyperglycemic agents. I would undertake these changes and safety netting with his GP, as well as refer him to an endocrinologist to elicit help from other allied health professionals to assist with monitoring his comorbidities and possibly providing additional financial support due to the chance of Mr. X not being able to conduct the same line of work. More specifically, I would gather further information and then you would go on and elaborate how you would expand on your history corroborating process that you highlighted at the start of your first line of your management plan. And then from there, you would split down each point into individual steps and finer details. As I highlighted before, the advantage of this structure allows you to provide a quick insight into the depth of your personalized plan without having to describe all the details in the first place. Sometimes this display of depth will make the examiners comfortable enough to pass that issue and move to the next, or it will allow them to identify the points within your response that they wish to jump to. Examiners jumping to points you have raised is usually a good thing, as they have likely identified a topic where they think that you can demonstrate deeper understanding and thus score more points. Remember, the examiners want to pass you, so follow their lead with questioning. This doesn't mean you have to always agree with them, but always take the time to consider what they are saying. Why are they saying it? And if what they said creates a counterbalance. Interesting discussion of pros and cons with something you raised, because any sort of discussion along those lines, as I said, is a gold mine. Other important points just to keep in consideration with the discussion section is to remember to own the patient and their management. So using I statements is important, and not referring to specialists until you have completed all that you reasonably can. The depth of knowledge expected is that of a generalist advanced trainee. They don't expect the minute details of the written examination and often will shy away from them for broader topics of conversation. There are issues and associated discussions which are much more common than others. So you should in your preparation make pre-prepared responses for these, but also practice adjusting them to meet the needs of the particular patient you have seen. Because if you don't adjust your plan to meet the patient in front of you and just say a generic response, this will be to your detriment. Some examples of commonly seen issues for discussion include bleeding versus clotting, infection versus immunosuppression, falls, smoking, alcohol abuse, depression, peri-op planning, adherence, driving suitability, and discharge planning. So you should pre-plan some management plans for these. With regards to finding and sharing cases, it is usually best to ask the advanced trainees and consultants on teams, as well as other trainees. The level of appropriateness of these patients will vary, so it is best to clarify if the patient has at least 2 significant medical conditions and additionally a psychosocial issue. It's even better if there are 2 conflicting issues, as I've said. However, when you're asking these questions, it's important to try not to gather too much intel before you see the patient. More importantly, however, it is important to check if the patient is appropriate with the team before seeing them, and then also clarifying with the patient if they were willing to participate. As you get closer to the clinical exam, some patients will get burnt out, so you need to respect their wishes and make sure to communicate those wishes to the wider group if necessary. There are multiple ways to practice for the long case. Obviously, performing long cases is the most common way to prepare. And for many people, it is a question of how many long cases do you need to do, but this is completely a personal choice, and it is to do as many until you feel you're comfortable with the process and that you are scoring consistently well. But in saying that, you also need to counterbalance it with not over-exhausting yourself. If you find you are doing too many cases to the point that it's impairing your energy level, you'll probably also find that your results will also be impaired. So be prepared to reflect and to find the balance that works best for you. With respect to long cases, they can be performed hot, which means in exam-like conditions where you see the patient, you have 10 minutes of consolidation, and then you present, or cold, where you see the patient and then present at a much later time. Either is appropriate at the start, but hot are better towards the exam times. With respect to the cold presentations, I would recommend that you take the history, but if you know you can't present straight away, holding off on the consolidation period until just before your presentation. This allows at least a semi-hot element to the process, and which is usually more beneficial. Sometimes it is hard to undertake a traditional hot long case. Alternatives would include writing summaries and issues based on other people's presentations, such as when you're watching the long cases. You could also represent old cases by making sure you incorporate feedback to demonstrate improvement. And I know of one person who used AI to help them generate history taking and content for them to practice not only consolidating but also the history taking process. Some considerations when presenting your long case in order to get the most out of them would be when approaching your examiner, providing them with a copy of the marking schema, as they may not have seen it for a while. Also telling them your weaknesses and where you're focused on improving beforehand so that they can put extra focus there as well. You should organize the time and place as early as possible, and make sure to keep your work team up to date so that you are more likely to actually have that availability when you require it. And when you're planning to do it hot, make sure you have a backup patient or a backup prepared cold case if required. It is not uncommon for your first patient to be whisked away for a test and then your second to change their mind. So having an old case or unpresented case in your briefcase is usually very handy. So some usual resources I use for the long case. Again, all of these are personal recommendations, but I found How to Pass the RACP Written and Clinical Exams by Rouse and Johnson to be very useful. Basically, it covers the whole BPT journey and provides numerous good insights. Then there's Talley and O'Connor's Examination Medicine, a guide to physicians training. Basically, this is the rule book a lot of people, including markers, refer to, especially for short cases, but they also have some very good insights for longs. The Royal Alfred BPT course has great demonstrations of advanced trainees presenting long cases of their patients. And Christine Barker's Rock Your Long Case. This offers presentations on common content and ways of approaching the long case, as well as has interactive courses with her own tutors. If you're interested in her content, she also has a YouTube channel where you can find out about her style of teaching. And this resource also has some great insights for the written exam as well. The clinical exam and preparation is stressful. If on your reflections you become aware you are struggling with either the content, finding time to practice, presenting in a coherent manner, or you're just experiencing some anxiety, then I recommend reaching out to either your DPE, a psychologist, or public speaking groups like Toastmasters if your issues are mainly around the presenting aspect. It is also important in these situations to let your support structures know, and equally important to remember that you're way more than just a candidate. My key point for this presentation is put your focus for the clinical exam on the long case. By far, the long case is where the majority of your marks can be found. You will be tempted to do more and more short cases, as these often draw up more anxiety due to the fast-paced nature and breadth of presentations. However, if you are scoring well in a long case, on the day your pressure to score well on the short case is dramatically decreased, but this does not work in reverse. So keep your focus on the long cases when you're on your lead up in preparation for the clinical exam. That concludes my presentation on the long case. Thank you for watching and good luck on your journey.